My topic is review of common and uncommon CTO complication. So I'm sorry, I have the other rules after finishing my presentation that I should go out the other room. So this is the data of the few years back, the data of the our registry of the CTO intervention in Japan. So we enrolled more than 2,000 CT class induced nephropathy of the 0.3 and the side branch occlusion of 0.09, and also the other every complication incidence is very low. So MACE is also very low in our procedure. So but in terms of the retrograde channel injury, we could see the channel injury, the 210 cases, but the treatment required in 61. That meaning the 30% of the channel injury should be treated by some hemostasis procedure. So and also the 4.2% of the channel perforation is associated with making the cardiac tamponade. So this is data of the septal channel and the epicardial channel data. So we used 1,235 septal channel for the retrograde, and also around the 500 epicardial channel were used for the retrograde approach. But the channel injury incidence is almost similar between these two collateral channels. So I showed some data about the channel perforation. Usually septal perforation we can leave it. Sorry. This case very long RC CTO. And before the procedure, I took the magistral CT. You can see the very calcified and the bending CTO is proximal RCA. So of course I started that, and the delayed approach has been failed. So this is the septal channel connection. So the second septal seems to be connected, but the channel itself looks very tortuous. The first one and the third one is also very misty. So I started from the channel negotiation from the second septal. So this is the chip injection, the second septal. You can see it's a very after corkscrew type of the channel, some connection between the to the PD branch. So, but unfortunately, XDR can make it the perforation inside the septal. But this is chip injection after making the perforation. You can see the staining of the contrast. So this kind of the hematoma usually leave it. So I switched to the retrograde from the first septal. The first septal is very misty, but fortunately 003 could be passed to the PD branch. Yeah, like this. So anyway, putting the this is after crossing the 003, we checked the angiogram and put the microcaster, and then we move to the reverse card to recognize the CTO. This is the final result. So the final result is very nice. But before finishing the case, so I checked the left coronary system again. You can see the hematoma becomes a little bit bigger than before. So in this kind of the bigger hematoma, we need to some hemostasis procedure. So nowadays, in Japan, the C stopper coil is come from the Piorax. This is the embolic coil is available for the 14,000 systems. So that we can put this coil using by the fine cross or the Corsair. It's very convenient compared with the conventional one. So this is the design. So for this case, we put the two C stopper coil like this. So after putting the coil, we never seen the hematoma inside in the septal channel. So usually we can leave this hematoma of the in the septal after making the perforation, but sometimes we met this kind of the situation. So the other case, this is also the little grade case, is you can see some bending channel from the LAD distal to the PD. Other times, unfortunately, CON wire can make the perforation like this, but the small, very small perforation, we left it and back to the undergrade approach. But during the undergrade approach, patient pressure has been decreasing gradually. So we checked the left coronary system again. As you can see, some hemorrhage is continued. So we put something the thrombus to achieve the hemostasis, but we need to the pericardial drainage to treatment cardiac tamponade. And also channel perforation in the epicardial channel, sometimes it's very risky. You can see is this is some connection from the AC branch to the AV branch, like this. So I used this channel for the retrograde approach. Channel tracking itself is not so difficult. So and then putting the microcatheter and the reverse card, and we always cover the channel by microcatheter like this to prevent the hemorrhage. After finishing this case, we checked the bilateral chip injection, but we can see the very big hemorrhage. The channel perforation is there, is bending portion. So we put the original coil. I'm sorry, it doesn't work. So, but we could achieve the hemostasis. And the other complication during the CTO intervention, usually CTO intervention procedure time is a little bit longer than the non-CTO procedure. So we should keep it ACT more than 300, but sometimes we made it this kind of the thrombogenic complication. This is CCTO. It's a very long one. You can see the distal. So we after failure of the antegrade approach, I used the retrograde approach from the RB branch. So after crossing the wire, we treated by the single guiding catheter. So this is almost final shot, but you can see that something is go down to the distal RCA. So again, as we can see, here is a very big hematoma. This is come from the antegrade guiding. So for that case, we can try to retrieve it by the aspiration catheter, but finally I failed. So we put this thrombus to the PD branch, so that we lost the PD branch like this. And also the other case, okay, I finished that in soon. Yeah. This is the left main LED just CDO. So anyway, after crossing the channel, we use a retrograde approach, so reverse card. But the patient complained chest pain and the blood pressure has been down. So we checked the antegrade flow. So left main is occluded. Fortunately, this patient is the circumflex very small. So we try to aspirate the thrombus like this. After aspiration, so the circumflex flow recovered and the patient condition will be better. So this is a retrievable thrombus from the left main. So originally this is come from the antegrade guiding. So we should always care about this kind of complication, retrograde approach. So and also I showed some iatrogenic complication. Antegrade injection after reverse card is sometimes risky. So this is RCCTO. So anyway, we use the retrograde approach. and gently antegrade short. Sometimes it's okay. We can confirm the stenting position. So, but the operator injected again. So that you can see the hematoma from the antegrade to the AV branch. So that we need to the additional 3 stents like this. The final shot is okay, but we need to the very long stenting for these cases. So the other case is more, sometimes we made it a very trivial situation. So this case is also RC CDO. Is after using the liver scut and recognize the CDO, the operator shoot the antegrade shot before stenting. So the antegrade shot can make it the perforation like this. So in the IVAS findings, it's very important findings, so that I would like to show that a little bit long time, so I'm sorry. But you can see is IVAS catheter completely outside of the vessel from here. This is vessel. So that maybe antegrade shot can make it perforation from the subintimal space. So the final my case is fracture of the microcatheter. This is a less circumflex CDO, the very calcified after failure of the antegrade approach. So you use the epicardial channel for the retrograde and the reverse cut. And after externalization, this is 1.5 balloon, but you can see something the tip of the balloon. Again, you can see. So we carefully retrieved the balloon. So we can see the chip of the calabar is fractured inside the CTO. Maybe because of the calcification. So this is summary of my presentation. In retrograde approach, incidence of the complication is very low. But however, 30% of the perforated channel require the hemostasis procedure. Usually septal channel perforation can be left, but when hematoma becomes bigger during the procedure, hemostasis procedure is required. And the retrograde specific complication, as I mentioned, that should be known to complete the retrograde approach. Thank you for your attention.
Good afternoon. Thank you, moderators. Thank you, chairperson. The basic difference, I think, between an antegrade and a retrograde PCI is that when you try to navigate an antegrade PCI, you are basically dealing with an artery which is supplying no area of myocardium or basically minimal 5 to 10% of the myocardium. While when you are dealing or while you are doing a retrograde case, you are dealing with the whole supply of the myocardium. So if you have any kind of complication, you are jeopardizing the whole of myocardium and you are increasing the risk of on-table MACE events. Okay, so that is what we are going to discuss in this session. And one thing I would like to make a point is that there is nothing like a basic retrograde PCI. Every retrograde PCI is a complex procedure. Just as we learn about antegrade cases that we have type A lesions, type B lesions, there is nothing like a retrograde. Retrograde is like the summit of all coronary interventions. If you take a look at the retrograde CTO PCI series, usually the antegrade cases we had a success rate of around 60 to 70%, but with the introduction of retrograde techniques, the success rates have increased to around 80-90% or so. In Japanese series, probably it's around 90-92%. Complication rates in major centers, people who are doing large number of cases, maybe more than 50 or retrograde cases in a year, they have MACE rates events less than 5%, while people who are doing less number of cases, they are having more incidence of major adverse cardiovascular events. So that is the basic difference. So what are the donor artery complications which we are looking at? So we have channel perforations, septal or epicardial perforations. We can have donor artery trouble in the form of thrombus, dissection, hemodynamic compromise, and collateral channel ischemia. So let's start with a case first. This is a case which we operated maybe around 15 days back only. This patient had an anterior wall MI 3 months back. So his LAD was stented and his RCA at that time, this kind of an good antegrade channel or dual injection was not taken at that point of time. So we planned to do his RCA CTO 3 months later on, and this was the picture when we did his dual injection. So you can see a very good channel actually, and we attempted this CTO antegradely. but inadvertently we failed and we crossed into a false lumen. So we had to attempt this case retrogradely. Retrogradely we could finally do this case well. You can see we had crossed into the retrograde channel, we have stented it completely. There was good TIMI3 flow into the RCA. But yes, after that, once we removed all the microcatheter and the retrograde Corsair, what we see is that there is a large perforation into the collateral channel in which we had taken our Corsair or microcatheter. That's another angle in which you can see that perforation. So what we did for this patient did not have any chest pain, patient did not have any hypotension, there were no ECG changes as such. So we just observed the patient, we did an echocardiogram for the patient, there was no pericardial effusion, there was no increase in the septal thickness, the patient was just observed for next 24 to 48 hours and then after that discharged. So what happens with these septal perforations? So septal perforation occurs when you have a microcatheter which is advanced over an extraluminar guide wire. Your guide wire is not in proper place, your passage of microcatheter or balloon dilatation of a very small tortuous septal collateral. So what is in the previous case in which I had shown to you, this is what has happened. We had did aggressive Corsair pushing of the aggressive Corsair. I think people tell us that you take 10 clockwise rotation, 10 counterclockwise rotation and then try to push the Corsair microcatheter. I think we did less than that, but despite that we had this kind of a perforation. Or third thing in this which can happen is that withdrawal of an externalized guide wire without advancement of the microcatheter to the antegrade guide. So septal channel perforation, I think safe is a myth. You can have dry tamponade. Dry tamponade means when you have large septal hematomas, these septal hematomas can cause inflow obstructions, can cause outflow obstruction. So they can cause left ventricular outflow tract obstruction leading to biventricular cardiac obstructive shock. You can have low septal hematomas near PDS which can cause pericardial tamponade. You can have septal hematomas also can lead to VSDs. So this is a picture which is showing the echocardiographic pictures of septal hematomas. VSD, LVOT obstruction due to increase in the septal thickness and fistula formation. So usually what do we need? I think Dr. Nasu already explained it. Usually we don't need any specific treatment for it unless and until its size is increasing. You observe the patient for chest pain, you observe the patient for hypertension. You need fenestration or embolization only if considered if you have chest pain is developing and there is a large or enlarging septal hematoma, high septal hematomas or low PDA position hematomas. And you need to, I think Dr. Surya Prakash also mentioned it, you need to obliterate both antegrade and the retrograde ends of the feeder vessels. This is another case. This was a live case done during last year's IJ CTO conference. You can see that there is an RCA CTO with bridging collaterals communicating with the distal RCA. There is an epicardial collateral which is communicating to the distal RCA. The retrograde CTO through the LAD was attempted already and it had failed. So this time it was decided that we had to do epicardial collateral from the ipsilateral side itself. So epicardial collaterals were tried from you can see there is a Corsair microcatheter which is going into the epicardial microcatheter. At the same time patient starts developing chest pain and there were some ECG changes. We knew that we are in some kind of trouble. Probably we had perforated the epicardial collateral. This is after probably after 2-3 hours after doing the procedure. So immediately what we did was we tried to retrogradely, we tried to put the microcoil and we successfully put the microcoil. And then we tried to put a chip injection. In the chip injection, you can see that at the end there is still some kind of an extravasation of dye into the pericardium, probably the pericardial cavity. And that is the point we decided that we have to close the antegrade limb of the feeder vessel. Then we successfully closed the antegrade limb of the feeder vessel and then completed the case. And then this is the final picture. This is a similar case, probably this is antegrade CTO PCI attempted first. See, you can see that there is an LCX CTO, there is a long segment LED lesion. See, we had tried to cross, this is the case done by one of my colleague. He tried to cross that anti-grade CTO with a hydrophilic wire, and then there is a perforation. So then what he did was he tried to close that with a balloon inflation, okay, but despite that, despite closing the balloon, doing the balloon inflation and pericardiocentesis, the patient still had hypotension, persistent hypotension. So then it was decided that we had to do a retrograde injection and try to see whether it closes itself or not. So there was a microcatheter was passed retrogradely, and we tried to close that with a retrograde injection. But what happened is that usually when you inject a glue, it's like hit and run. You cannot stay there for a period of time. So probably what happened, I don't know, but the glue was injected and the corsair was tried to be pulled out, but the corsair could not be pulled out in that situation. And then despite that, the patient had chest pain, persistent hypotension and all. So patient went for CABG. In CABG, even the CVTS surgeon could not extract the corsair microcatheter, and that corsair microcatheter had to be left alone after putting all the grafts. Very unusual case, but yes, these things can happen. So epicardial collateral perforation, very serious retrograde complication, can lead to rapid tamponade, difficult to control, usually due to aggressive wire advancement through tortuous epicardial collaterals and advancement of microcatheters after a perforation has occurred. That is why I think in septal channels you say that the size is more important, because even if you have a perforation it can be managed, while in collaterals you say the size is not important, it is the tortuosity which is important. Treatment of such kind of perforation, it is a true emergency requiring immediate correction. Negative pressure applied from the wedge microcatheter for 10 to 15 minutes, bilateral angiography, embolization of coils, clue, clotted blood or thrombin. Sorry, just a minute, just. So learning points are basically microcatheter selective contrasted guide wire and advancement is needed. Surfing should never be done in epicardial collaterals. That is what we do. Surfing means that you find the path of least resistance in septal collaterals. But that should never be done in a case of epicardial collateral, because whatever, if you're trying to find the path of least resistance, maybe you might perforate it out. Never balloon dilate an epicardial collateral. Probably you can see that post CABG patients, they are less likely to go into tamponade because they are open chested, but even then they can have left atrial hematomas which can lead to inflow obstruction and pulmonary edema and shock. Donor arteries, I think Dr. Nasu had already explained, so I'll skip it out. Checking ACT every 15 minutes. This is a case of donor artery dissection. I think the media is not getting played.
It's okay.
So usually donor artery dissection occurs when you try to pull out the corsair or the microcatheter, despite not holding the guides which we are there in the retrograde limb. So you have to use short guides and you have to disengage your retrograde guide to mid-ascending aorta during microcatheter pullback, and pre-plan use of shorter guides and longer microcatheters. So this is a case of donor guiding deep throating which is occurring when you try to pull out the corsair microcatheter. You can see as you try to pull out the microcatheter, your RCA guide is getting deeply engaged and the patient is developing chest pain, hypertension and global ECG changes. You can have donor artery ischemia due to untreated lesions. This was an initial antegrade attempt which was made. It failed out because you could not find the lumen. There was a good septal collateral. And there was initially in that case there was a dissection in the LAD territory and there was failure to deliver the stent, and that lesion was left alone at that point of time. The RCA CTA was attempted through the septal collateral. As we tried to cross the RCA CTO, patient became hypotensive. ST, it became elevated globally. What we did was we overlooked the LAD. The LAD had to be treated first. So at that point of time, the LAD mid and the LAD proximal stenting was done. And after securing the mid LAD and the proximal LAD, the RCA CTO was recanalized using a reverse cart technique. This is the final picture.
Okay.
I think which is there is a time.
I think it's a good presentation of very rare complications and expected complications.
Thank you. My conclusion over the world over the drop patient is the most important. So it is reasonable to abandon an ischemia causing collateral or donor artery and search for an alternative collateral to minimize the ischemic risk to the patient. And we need to be proctored because retrograde PCI has got a steep learning curve, and hence one should get proctored by experienced CTO operators to minimize avoidable complications in retrograde PCI. Thank you.
Thank you for chairperson and moderators. I'll try to see if I can do this fast and gain some time. So really, the scope of this talk is just to go over some of the mechanical support devices that are available for this high-risk PCI, whether it's chip, slip, whatever you want to call this procedures. And I think it starts by what is the rationale for this. And the rationale is an inability of a high-risk patient, like the ones that have been shown before, to be able to maintain or tolerate the hemodynamic consequences of dysrhythmia, transient ischemia, reperfusion, or atherogenic material going and having the no reflow phenomena, as it was shown yesterday in the case with Dr. Colombo. Again, these are high-risk patients, and what we're trying to do is try to minimize these issues. Now, what it comes down is to really what is the definition of that high-risk patient, and I think every one of you guys will have to do that in your practice. But in general, this definition is based on a clinical criteria and an anatomic criteria and a hemodynamic criteria. So you have to look at the patient, you have to look at the lesion that you're going to be dealing with, and you have to look at what the hemodynamics are. So obviously, low ejection fraction patients with a complex PCI, whether it's left main bifurcation, multi-vessel, high syntax scores, and or patients with hemodynamic instability, low cardiac output, a high wedge, or pulmonary hypertension. So when you start combining more of this characteristics, then this patient becomes higher risk. What are the benefits of mechanical support? Basically, you are augmenting mean arterial pressure. The case that was shown yesterday where when Dr. Colombo, you saw that during balloon occlusion, the pressure went down, but it was maintained. And then also you have maintaining end organ perfusion, so you maintain kidney perfusion, and you are optimizing myocardial perfusion by lowering the end diastolic pressures, especially if you're using a device that unloads the left ventricle. And by unloading the left ventricle, you're minimizing the oxygen demand. So really the goals are two main goals. One is to maintain hemodynamics, and the other one is to facilitate the completeness of the treatment. So one thing that has been shown as you use some of these mechanical devices, you can do more complete revascularization and target more vessels to have a more complete result. So what are the options? The intra-aortic balloon pump would be the more basic one, and as you move to other devices, then you go into the Impella, the PHP, and then tandem heart and the ECMO, and I'll go over them and what the spectrum and when you can use one or the other. So again, the difference between these devices are here, and there are many tables that show, but just starting with the intra-aortic balloon, basically you have a device that everyone is very familiar with it. It's easy to place, but really the cardiac output augmentation that you get is only around half a liter. There's no major left ventricular end diastolic unloading, and the myocardial oxygen demand, you don't change it too much. So it's very basic. There have been a few trials done in cardiogenic shock to see if the balloon compared to either no balloon or other devices have been done. And these are the trials. There's a shock, the BCIS, and the CRIS. And overall, even though it's the most commonly used device when you look at mechanical support on over 230,000 patients, 70% of those procedures were using a balloon whenever something was used. The reality is that there's no data showing that there's significant improvement in survival using the balloon pump, whether it's in the shock trial, the shock 2 trial. None of them have shown any significant benefit in emergency revascularization. So in summary, in terms of the intra-aortic balloon, there's no clear data supporting the routine usage of the intra-aortic balloon pump. It has limited cardiac output augmentation. It has limited left ventricular unloading and decreasing myocardial oxygen. And therefore, when you look at the guidelines, you have a class 2A indication for patients that become hemodynamically stable, and the routine usage of the intra-aortic balloon with cardiogenic shock is not recommended. In fact, it's a class 3 indication. As we move to a more advanced device, the Impella, which has just got approval in India. This device gives you more support, anywhere between 1.5 liters to actually 5 liters, depending on the device that you use. You have unloading of the left ventricle, decreasing of myocardial oxygen demand, and really this is kind of the more used device in the modern era. And the Impella CP, which is their newer device, is probably the most commonly used. As you know, there's a 2.5, and now when the CP came into the market, which has the same 14 French access, then as you get 3.5 to 4 liters of support, this becomes a little bit more versatile. There's a 5.0, but usually that needs a cut down and usually surgical insertion. And they have an RP for support of the right ventricle. But the Impella is more versatile. It increases flow, it increases mean arterial pressure, and it decreases left ventricular and diastolic pressures and in diastolic volume, which results in increase in cardiac power output, which helps for end organ perfusion, increases oxygen supply, and decreases oxygen demand. So you get all benefits from support. This is an example of a case, and this is what we saw yesterday, that if you have the Impella, so on the lower part you have no Impella support, you are able to maintain the pressure depending on the balloon inflation and the time. When you are inflating for 30 seconds, 40 seconds, then obviously the decrease in blood pressure is significant. With the Impella, you're able to maintain that pressure. There have been multiple studies looking at the benefits of Impella, and these are some of the studies: Protect 1, the ICER shock, and then the more recent ones, Protect 2 and Recover. But basically, when you combine those studies, and that was a combination of either comparing to something which usually was the intra-aortic balloon or no other support, the summary is as follows. You have less hypotensive episodes with protected PCI, so that we have shown before. You saw it in the case yesterday. You have increased myocardial perfusion with the Impella, so your coronary blood flow is maintained, and with the support, it actually increases your coronary blood flow. You prevent that hemodynamic compromise and collapse, so you maintain blood pressure, and compared to intra-aortic balloon pump, you have a much better effect than you do you have with the Impella than with the intra-aortic balloon pump. And the cardiac power output, as you guys know, is the mean arterial pressure times your cardiac output times the 0.002, basically is maintained. And that improving cardiac power output has been shown to be the most correlated with improved mortality. The other important effect of having mechanical support is that it allows you to complete the procedure. So since you have more stability, you can move from taking care of 1 vessel, 2 vessels, and 3 vessels. So when you look at the studies compared to an intra-aortic balloon pump, you were able to do more complete revascularization, and maybe that's why you have seen that later on there may be some benefit in MACE related to that more complete revascularization, which is kind of what we have seen in the surgical world. So the other thing is it's about end organ perfusion. When you look at the incidence of acute kidney injury with or without dialysis, while comparing Impella to the control, the Impella group did better. Less acute kidney injury because you're perfusing the organs, you're maintaining blood pressure, and certainly less events of hemolysis. Same thing is being shown for left ventricular ejection fraction. There's improvement on every study, and some of that data has been shown. When you look at the real world, what's Impella being used, most of the cases are for elective and urgent PCI, and around 50%, and then around 35% is for cardiogenic shock. So kind of a mix of half and half. This is the same that I showed before. There's improvement in ejection fraction, and then also there has been shown to have some cost effectiveness depending on the markets. And therefore, based on all the studies, there's a expert consensus study, and the guidelines are here where you have PCI and cardiogenic shock, a class 1 indication, and you can see there what the more recent ones are. So from the Impella standpoint, the benefits is technically it's easy, has the clinical and the hemodynamic support, and has some data to show the improvement. You have other options, like I mentioned, a 2.5 and a 5.0. The 5.0 usually is an axillary. And then you can also do a bipella where you put basically 2 devices for biventricular support. There's a small study showing that there's some benefits on biventricular support. A similar device is the HeartMate PHP. The PHP is Thoratec. There's a clinical trial in the US that was started, and basically it's a similar device. And what it has, it goes through a 14 sheath, and then you take the sheath back, and then this becomes a 24 French. So you end up with the impeller in the similar position that appears to have less movement than the Impella, and it appears because of the way the channels are made within the impeller that perhaps will have less hemolysis. However, the trial in the US was stopped, so if you go to the website, it'll tell you that it's been stopped. From what I hear, it's going to be restarted in the next couple of months. I think there was some production issues and some issues with the catheter. I really don't know exactly what the problem was, but I think from what I hear, it's going to get restarted. There's a device, an RCP device, and basically this is just a little pump that you put in the descending aorta. It can give you a 30% augmentation on cardiac output. It unloads the ventricle a little bit, so you don't have the issues that you have to put it across the aortic valve, and you can just leave it in the descending aorta. And there's some studies ongoing now with this device. There's not commercially available, but I think there's some trials. So you'll see more of these pumps where you don't have to go across the aortic valve. You can use them for support. So it gives you more than a balloon, but less than an Impella, or something like a tandem heart, which would be your next level. The advantage of the tandem heart is that you have more configuration, so you can do veno-arterial, RA to PA, LA to FA, and then the only issues you have to, this is a transeptal approach, it's a 21 French cannula, so there are issues with transeptal, and you have to have versatility with that. As far as trials, there are not a lot of trials that are being looking at that, and the tandem per chip is something that in most places is not used, unless you really think that the patient is going to need a lot of support and is going to need ECMO later on. Because then you can convert and you can put an oxygenator on the device if you want to, and obviously ECMO would be your final support, where you can basically, usually these are patients who were completely crashed, cardiogenic shock. You put them on ECMO, and then you go and do a PCI because the patient is not a candidate for surgery. So when you look at all your options, you basically have a balloon pump, you have ECMO, you tandem heart, Impella, RCP, or the HP, And basically, if you want to unload the ventricle, you either need a tandem heart, Impella, or ECMO. Balloon pump doesn't give you a lot of support. And the only other thing I just want to go over is over the contraindications and complications. So for the intra-aortic balloon, as you guys know, moderate to severe aortic insufficiency and peripheral vascular disease. The Impella, if you have aortic valve issues with aortic stenosis, there may be a contraindication. And tandem heart, again, you have to be able to anticoagulate the patient, and you have to, if you have a VSD, there's a contraindication. So as a final thing, when you look at high-risk PCI and an unprotected left main, for instance, someone with an ejection fraction that is low or complex case, then I think that you should start thinking of which device may be beneficial for you. If there's not a lot of peripheral vascular disease, you move to probably the workhorse, which is the Impella CP. This gives you the spectrum of cardiac support, and depending on how much liters or how much cardiac output support you need, then you move to the right or the left, depending. So in conclusion, mechanical support is indicated and beneficial for selected patients undergoing high-risk PCI. Different devices can be used depending on the clinical situation. More studies are really needed to know the true value of these devices. And I think in the future, the devices are going to get smaller and easier to deploy with less hemolysis and vascular complications. Thank you very much.